Absolutely. Good evening, everybody. On behalf of IPS office and IPS Psychopharmacology Specialty Section, I welcome you all uh, for the first webinar from Psychopharmacology Specialty Section. Today we'll be talking about, discussing about an old drug, which is disulfiram. We just wanted to revisit disulfiram. We all know about disulfiram, but we haven't re-rated its position in current modern contemporary psychiatry. Now that many drugs in treatment of alcoholism are available, like naltrexone, acamprosate, baclofen, topiramate. So we would like to know about what is the current status of disulfiram in modern day practice. And for that, we have uh, eminent speaker and a chairperson. May I request admin to put on the slide of introduction of the chairperson, please? So for today, we have Dr. Bhatia, who is MD and DM Addiction Psychiatry, who's going to chair today's session. She's associate professor at Amrita Institute of Medical Sciences and Research at Faridabad. Her career has been decorated with many awards and achievements. Her areas of interest are substance use disorders, and which is relevant for today. We welcome ma'am. Uh, I now request Dr. Marwade sir, Dr. OP Singh sir, and Dr. Sujit sir to speak a few words before we begin with the session today.
We'll start with OP, sir.
We'll start with OP sir. OP sir, please.
OP, sir, your remarks, please.
Yes, sir. Sorry, I was unmuting. So, of course, sir, my best wishes to this program and the committee under leadership of Hina and chairpersons is doing great work, Saul. And we have Dr. Abhishek Ghosh, who is really stalwart in the field of addiction medicine. Dr. Gayatri, I can see, and George is there. So my best wishes to all of you. And we know that disulfiram is still being used, and it will be good to know about the nuances which is happening. So thank you and my best wishes.
Okay. So, thank you, Govind. Uh, Respected advisor, Dr. Anurag, sir. Then Dr. Das. Chairperson, Dr. Shahul Amin. Co-chairpersons, Govind Kulkarni and Ramandeep, sir. Convener, Simon Aule. Members, Vaibhav, Anupama, and Ratnesh, and all the office bearers, Dr. OP sir, our vice president come president elect, our editor sir, Sujit Sarkel, treasurer Naresh Wadlamani, and the EC member Dr. Hina. Today's session's chairperson Gayatri Bhatia, who has completed her MD in Pune, Bharati Vidyapit, and then later DM from AIMS, and she is working, I think, at Rajkot right now. And the eminent speaker, Dr. Abhishek Ghosh. So, good evening, everybody. The topic you have chosen is definitely a very useful topic because amongst the medications which are used for alcohol dependence, this is the only drug which gives almost 60% very early after the after we start available. They will take pretty long time, and the if it works, it works. Otherwise, it won't work at all. So that's the position management of alcoholism goes. So wonderful, and I wish all such wonderful sessions in the future also. So I will. It's time. Thank you. Sujit, Dr. Sujit Sarkel, your comments, please.
Yes. Thank you, sir, and big congratulations to the psychopharmacology team for having thought of and conceived this topic. And I think it is going to be a good exposure to all the PGs. I personally requested many of my PGs to join because the use of disulfiram has gone down significantly compared to our PG days. And I think many of the current PGs are not properly exposed to the drug, its use. So I think the session from Dr. Abhishek Ghosh should be kind of an exposure to the people who have not been exposed, and for people like us, it would be more of a revisit with the recent updates, if any. So, without much delay, I would like to hand over the proceedings to the psychopharmacology team so that the lecture can be started at the earliest. Thank you and wish all the best to the team.
Over to Dr. Bhatia, please.
A very good evening to everybody. I, on behalf of the whole IPS team, welcome everybody who's spent their time and attended this uh, evening with, I'm hoping, an intense intellectual discussion on the use of disulfiram in current detailing in current environment. As I understand from our training days, we've learned about disulfiram as one of the first FDA approved molecules to be approved as first line agent for alcohol use disorders. And philosophically speaking, disulfiram has seen it all. It has seen it being used as a punishment. It has been seen itself being used as a deterrent, and now as a first line treatment. But still, in current day and age, when more and more people are opting for controlled drinking rather than total abstinence, it is the time when we actually need to revisit the role of disulfiram. So it is my honor and pleasure to introduce Dr. Abhishek Ghosh, our esteemed speaker for the day. Dr. Abhishek Ghosh is currently working as an additional professor at PGI Chandigarh, and he has done his MD as well as DM and happens to be a stalwart in the field of addiction psychiatry with multiple national and international awards. Sir has been a good, talented researcher with a lot of clinical trial experience. His interests are mixed method research and implementation research, along with some good evidence synthesis. And we all have read his research work and we've all been inspired by it. And I think we are more than eager to listen to what Sir has to say today. So over to Dr. Abhishek.
Thank you very much, Gayatri. Yeah, it has been a pleasure to be able to talk to all of you today. And a big thank you to the Psychopharmacology subsection of the Indian Psychiatric Society for having me here today with all of you. So I was wondering, I was actually asking this question to Dr. Govind Kulkarni, that why was disulfiram chosen from all the drugs? Because it's not a new drug. I would say this is kind of the Gandalf of alcohol use disorder treatment. If you have read, I'm sure all of you must have read or watched the Hobbit and the so why now? Why do we need to revisit? Then I understood that at the psychopharmacology subsection, it's primarily targeting very new drugs like lumateperone, etc., and very old drugs, which are which needs a revisit, which needs to be discussed again to motivate people to prescribe it. So that's why disulfiram has come into the picture. So that history actually is very helpful and helped me to contextualize today's presentation. So before I start, I have a Slido poll for you. I will first share my slide to do the Slido poll, just to, it's kind of, you can take it just sort of a warm-up session. And I'm sure nowadays every one of you must have seen Slido, have experienced Slido. So this is the first Slido question. You can scan the QR code. An answer should be visible online. What is your medication of choice for long-term maintenance treatment for alcohol use disorder? The naltrexone is winning the race. Okay, it's a head-to-head. It's a very tough competition between naltrexone and acamprosate. Naltrexone seems to be winning the battle, and disulfiram is gradually losing out. Give it more time. Right. So baclofen has opened this account. So disulfiram in the second spot now. Very interesting, disulfiram, baclofen now competing with acamprosate. This looks like those exit poll or the poll results as they come up, live poll results. Okay, I think I will move to the next slide. It's very interesting and insightful to see that there are actually a lot of people who is not only prescribing disulfiram, but their medication of choice is disulfiram. Maybe we have a selective audience, very knowledgeable audience who have a lot of experience in using disulfiram, or maybe disulfiram is, we think that it is not prescribed, but it's not that bad. In fact, the acamprosate is the one which is the least prescribed, or maybe the the least among the 4 medications. Okay, I will move to the next slide now. So again, naltrexone, disulfiram, baclofen, and acamprosate. These are the order of things. Okay, this is the next one. Have you prescribed disulfiram for UD in the last 3 months? Right. So most of you have prescribed disulfiram in the last 3 months. That's great. Right. So I will move on to the next slide. Now, this is an open text where you can write what are your main concerns for prescribing disulfiram. Even if you are prescribing disulfiram, but you might be concerned about something. So whatever you write, it will be shown as word cloud. Consent. What is it? Consent? Yeah, the consent process is tedious, or disulfiram alcohol reaction, also known as disulfiram ethanol reaction. Yeah, so these are the same things. Interaction, so perhaps you were indicating drug interactions. The disulfiram ethanol reaction has come up as a major threat to disulfiram prescription, followed by consent. Some people are also kind of wary of non-adherence to disulfiram and maybe increasing the risk of disulfiram ethanol reaction. Patient goals, yeah. So somebody who is not motivated for complete abstinence or committed to complete abstinence, prescribing disulfiram, tricky. Consent process is tedious, again related to consent, not anti-craving. So yeah, so it's very interesting because it does not have any active mechanism of action. There's a reaction by adventures by patients, yeah. I guess nobody's typing now. So overall, disulfiram ethanol reaction perhaps is the single most, and followed by consent, they're the two most important concerns for prescribing disulfiram. So I hope that during my presentation, I will be dealing with both. And perhaps we can also discuss about these during the discussion. Well, that's all from the Slido side. Now we'll start with the presentation. Hope you can see my slides. I have just made it full screen, so I hope that you're able to see it full screen. I'm assuming yes. So this is the outline for today's presentation. First of all, we'll very briefly talk about very interesting and checkered history of disulfiram. How did it all start? Then I think Gayatri has already talked about that there was an initial enthusiasm of prescribing disulfiram, followed by, I would say, controlled optimism to rejection to some quarters. And we'll try and understand how and why did it happen. Of course, these are conjectures. Is disulfiram effective in the treatment of AUD? I think Dr. Govind has talked about it, right? What is the current evidence base for disulfiram and how does it compare with other pharmacological agents? Who are suitable candidates or not suitable candidates for disulfiram? How to choose, when to choose, and side effects and monitoring. We'll also discuss about that. The first, let us a little bit talk about the history of disulfiram. Very interesting. Disulfiram as a molecule was first discovered by a chemist, German chemist named Brodsky in 1881. But at that time, it seems there was a zeal of discovering new chemical entities. So his discovery was not noticed at all till the 1930s, when there was a huge flourish of the rubber industry, and disulfiram was used in the rubber industry. And interestingly, it was seen that the rubber industry workers would experience a notorious reaction when they consume alcohol. People could not wrap their head around what was happening. And of course, this goes completely unnoticed. In 1940s, two Danish researchers, they are also chemists, Erik Jacobsen and James Hall, they found that disulfiram is a copper chelating agent, so it can be used as anti-parasitic and anti-helminthic. Erik Jacobsen was also interested in testing all the drugs, on effect of all the drugs on his own body. So he took disulfiram just out of curiosity, that's what happens. And then he drank alcohol and experienced an unpleasant reaction. So he is the first one to discover, in that sense, that disulfiram and ethanol might interact with each other and produce an unpleasant reaction. And later on, they did apply disulfiram, prescribed disulfiram in a group of patients who suffer from alcohol use disorder. At that point in time, they are known as alcoholics, and alcohol use disorder was known as alcoholism. So in the next couple of slides, when I'll show you some snapshot of old research done in the 1960s and 70s, you will see this term very frequently, and don't castigate me for showing those because those are well approved, scientifically approved terms at that point in time. So he used it in a group of quote unquote alcoholics, and then voila, disulfiram was approved for the treatment of alcohol use disorder by the FDA in 1951. I think Gayatri has already talked about it. It's the first FDA-approved pharmacological agent for pharmacological treatment for alcohol use disorder. However, the practice of disulfiram was a little different than back in 1950s than it is now. That time, disulfiram was thought to be an aversive agent. So disulfiram challenge test was seen as a necessity for its effect on alcoholism. Therefore, people will give very high dosages of disulfiram to make sure that the person experience disulfiram ethanol reaction, up to 1 to 3 grams of disulfiram, which is quite unheard of nowadays. So this is definitely a change of practice which has happened over the years that I'll discuss later. So overall, disulfiram's discovery is a story of surprises, serendipity, and a lot of ingenuity. What I haven't mentioned here, but it's another interesting, I think, anecdote, is the discovery of the mechanism of action of disulfiram, or mechanism of action of the disulfiram ethanol reaction. It seems in their chemist lab, when they would produce disulfiram ethanol reaction, their Jacobson colleague will enter the lab and would smell of acetaldehyde. The lab would smell of acetaldehyde. And he would get this information to Jacobson, who would finally discover that disulfiram ethanol reaction happens because of the accumulation of acetaldehyde in the blood. So that is another interesting discovery. In the context of US, I think those of you who have seen Gayatri's CV slide must have noted that he has received a Ruth Fox Fellowship from the American Society of Addiction Medicine. You might have been wondering who was this lady. Ruth Fox is the first founding president of American Society of Addiction Medicine, and it seems she was the first person to prescribe and popularize disulfiram in the US in the 1950s. And it seems she has prescribed disulfiram in more than 2,500 patients. I'm sure had she been alive today, would have been very pleasantly surprised and maybe very glad to see that we are presenting disulfiram 8:30 p.m. in India. So, it is very old story, interesting story. 1960s and 70s, I would say this is the epoch of initial hype, where people thought that disulfiram is the panacea for the treatment of alcohol use disorder. You also should understand the context at that time. So there was no treatment available for alcohol use disorder. And people thought that abstinence is the only treatment goal for patients with alcohol use disorder. And this all were heavily influenced by the Alcoholics Anonymous dictum of abstinence. So the social context, the philosophy of treatment of alcohol use disorder treatment was quite different in the 1960s and 70s than it is now. So people who are not afraid of giving disulfiram and producing disulfiram ethanol reaction, I think that has come up as a major concern for you in the Slido. However, the paradox is, the irony is, at that point in time, it was thought to be a necessary evil for producing the disulfiram's effects on patients with alcohol use disorder, because they thought that aversive conditioning is the mechanism by which disulfiram produces effect. You also might recognize that was the time when behaviorism was on the fore. So people who are no longer interested in psychoanalytic therapy, they were interested in cognitive behavior therapy, the Skinner's behaviorism. Aversive conditioning fits just into that mold of behaviorism. So there is a lot of push of abstinence from Alcoholics Anonymous group. There is a lot of influence of behaviorism as a context, and disulfiram just fitted very well in that context. This is very important to understand this context, because then we'll realize why disulfiram might have lost its shine over the years. However, people started realizing a lot of toxic effects of disulfiram, because you must recognize that was the time when disulfiram was prescribed in very high dose. It was producing toxic neurological effects, psychological effects, especially delirium was reported, confusional state and delirium. And of course, disulfiram-induced psychosis and sudden death during disulfiram alcohol reaction. So people started to observe toxic effects, and I guess people also thought there might be some other ways of prescribing disulfiram which may not produce this toxic effect. So they came up with this, again, this ingenious idea of administering disulfiram not via oral route, but via subcutaneous route in the form of an implant, a disulfiram implant. And there was some initial literature, even some literature were published in the Lancet as well. Disulfiram implantation for alcoholism, disulfiram impact control trial. All these are very small sample size. It's not typically rigorous control, placebo-controlled trial as we do today. So the safety and effectiveness of disulfiram implant have always been questioned. It was discontinued after a couple of decades, and it was never licensed in the US. So most of this was happening in the Europe and the rest of the world. However, when I just got curious and tried to see whether people are still prescribing disulfiram implant, so I could get hold of these two research. Both are from Turkey, where disulfiram implant was applied in patients, administered on patients with alcohol use disorder and inpatients. However, I could not find literature from elsewhere. So I would not talk about disulfiram implant in the rest of my presentation. I have dedicated this couple of slides just to say, let you know that there was a time when implant was also there before it lost this importance in the way. So after the 1960s, 70s, and 80s, I would say 1990s and 2000, the time of recalibrated hope and rethinking the mechanism of disulfiram. And there, I think you would hear two names very frequently who are very much proponents of disulfiram. Both are from the UK, Jonathan Chick and Colin Brewer. So this is a very, it's a very famous paper. Those who prescribe disulfiram must have read this paper already, published in the British Journal of Psychiatry, 1992. So that has primarily talked about the mechanism of disulfiram. So they spoke about the disulfiram. It's kind of a package. So it's not only a drug, it's also a drug plus a psychosocial intervention when the doctor establishes a good therapeutic relationship with the patient, give a good dose of motivational enhancement, and make the patient committed for abstinence from alcohol, and at the same time emphasizing the importance of disulfiram ethanol reaction to produce a deterrent effect. So they, from an aversive conditioning, they have moved to a deterrent effect. From disulfiram as an active drug, these articles talked about disulfiram plus psychosocial interventions. Psychosocial intervention has several subcomponents that we have described. So disulfiram as a package. So they also questioned that if it is a deterrent effect, so if the aim of prescribing disulfiram is to create this fear, then why to prescribe high dose, which would just ensure very severe disulfiram ethanol reaction? So they recommended to use low doses of disulfiram, like the current doses we prescribed, 250 milligram is the standard dose, maximum of 500 milligram. That was the time in 1990s when they first talked about different mechanism of disulfiram and gave a rationale for using a lower dose of disulfiram. They also talked about supervised disulfiram. So before that, disulfiram was supervised, but supervised just in the clinical context. And people didn't talk about disulfiram supervised by spouse, supervised by community agencies, or supervised by employers. So they thought that within this package they have talked about, not only therapeutic relationship, not only a commitment for abstinence, not only the fear of creating a fear around disulfiram ethanol reaction, but also a supervision is important, because disulfiram to be effective, a person needs to adhere to the treatment, and to ensure adherence, supervised disulfiram could be an option. Supervised treatment with disulfiram has some effect on short-term abstinence until relapse. So this is kind of, again, you could see the names of Colin Brewer and also Jorgensen, Tonensen. So you'll see a lot of names from the Scandinavian countries, because you might remember my first slide where I talked about the history and evolution of disulfiram and talked about two Danish chemists who have first discovered disulfiram. And incidentally, Scandinavian countries are the countries in which a large number of patients are prescribed disulfiram nowadays as well, which I will discuss in my next slides. However, as I said, that this recalibration of it is not about all hope. There are people, these are two French articles. Basically, they are criticizing disulfiram. So you could I've just taken these quotes from these articles. Disulfiram represents a very notable pharmacotherapeutic anomaly. Very interesting, because they say that normally we regard a medication as effective if it deploys its pharmacological effect. This being the basis of any placebo-controlled trial. So placebo does not have any pharmacological effect on the body, whereas the active molecule should have a pharmacological effect on the body. However, disulfiram is supposed to be effective when it isn't producing a pharmacological effect. So as I said, disulfiram is effective because of its deterrent effect, because the fear it creates around disulfiram ethanol reaction, because of supervised disulfiram intake, because of the therapeutic relationship, because of the commitment to abstain from alcohol. So where is the therapeutic effect for disulfiram itself? So they question that perhaps disulfiram does not even, cannot even be called as a pharmacological agent. So I just wanted to, give you both the extremes. At one hand, there are Colin Brewer and Jonathan Chick and Hugh Benson's group, who are all gung-ho about disulfiram, but there is this other French group who generally, are kind of reluctant to prescribe disulfiram and do not consider them even as a medication. Well, interesting. So with this interesting history and kind of evolution, three-epoch evolution with initial lot of encouragement and hype and excitement, followed by recalibrated hope. Let us discuss how effective disulfiram is. So this is the recent 2023 JAMA review, where they have compared disulfiram and other pharmacological agent. So you could see the forest plot here, and the diamond lies straight in between. It's just odds risk ratio of 1. That means disulfiram is not effective in terms of return to any drinking when you compare it to placebo. So in randomized placebo-controlled, double-blind placebo-controlled trial, which is the gold standard for any pharmacotherapeutic agents to be called as effective and not effective, disulfiram doesn't pass the acid test. However, the authors noted that positive RCTs are attributed to small sample confounding effect of counseling. Here they are talking about the package that I have alluded to in my previous slides, and benefits of therapeutic relationship. Again, the package they are talking about. So it's very interesting that in 1990s, Jonathan Chaikin group has already talked about it and talked about package. And again, this is used as a limitation against disulfiram because it doesn't meet the randomized placebo-controlled trial standard. However, then you might say, what's the big deal? Let us stop the discussion here. Disulfiram is not significantly more effective than placebo for the treatment of alcohol use disorder in terms of return to healthy drinking. So let us stop talking about disulfiram and let us enjoy our dinner. However, there are meta-analysis. This Madeline Steiner's group, again, another person from the Scandinavian country, who is very interested in disulfiram research. You'll see a lot of articles by Madeline Skinner and her group. So they did meta-analysis, and here they've included both open-label trials and double-blind, placebo-controlled randomized trials. So that was the difference from the previous Journal of American Medical Association paper that I've discussed. They have several subgroup analysis. So they compared the results of double-blind RCT and open-label trial. They compared the result of supervised, unsupervised disulfiram. Those were dependent on cocaine and not dependent on cocaine. Why cocaine? Because I'll discuss in later slides that cocaine use disorder is another condition in which disulfiram has been tried in placebo-controlled trial. In fact, I'll discuss a meta-analysis which should show some encouraging results. Also assessed adverse events versus placebo. They gave a composite score regarding the success rate, which comprises of abstinence, days of drinking, time to first heavy drinking days. So it's they gave a composite score, not like the previous one, which talked only about return to any drinking. And the duration of the follow-up ranged from 8 to 52 weeks. So it's a very broad range, you could see. Here, very interestingly, when disulfiram is compared, this is the overall effect of disulfiram when you combine all open-label trial, placebo, double-blind, randomized controlled trials. You see a higher success rate defined, as I mentioned before, compared to controls with a modest effect size of 0.58. Here you could see the diamond is shining on the disulfiram side. As I said, they did a lot of subgroup analysis. One of the first subgroup analysis they did compared the results of double-blind placebo-controlled trial and non-blinded or open-label trials. And you could see the stark contrast between the result when you see the result of double-blind placebo-controlled trial. The diamond is right in the middle of the line, so that means it's not effective. Whereas when you see the open-label trial, you could see So you could see the diamond is shining again for disulfiram. So that means open-label trials show positive results. What that also indicates that people who are prescribed disulfiram, they should know that they are on disulfiram, and then only it will produce the fear effect. Again, it is indicating or suggesting the effect that was suggested by Jonathan Chick and his team that disulfiram itself is an inert molecule, but it has this package effect where the therapeutic relationship, the talk about disulfiram as a deterrent is actually the active ingredient. When they compare supervised versus unsupervised, so this is the unsupervised one. The line touches the 0 point, so it is not effective. Disulfiram is not effective in placebo, whereas when you do supervised, it is very much effective. So again, supervised disulfiram, Colin Brewer's and Jonathan Chick's group, as they propose, is kind of holds true here in this meta-analysis. Cocaine and non-cocaine here doesn't matter whether the person is cocaine dependent. For the first 3 trials, people are also dependent on cocaine, and the rest people are people do not have cocaine use disorder. They have exclusive alcohol use disorder. So in both the cases, you have the diamond shining for disulfiram. However, you could see the confidence interval a little more here, that the results are less precise because the sample size is small. However, the size of the diamond is larger. That also means the effect size is larger. So one would argue, or sometimes you might ask this question, that whether you would prefer to prescribe disulfiram over other drugs when somebody has comorbid cocaine use disorder. Now, how does disulfiram compare with other pharmacological agent? So this meta-analysis showed that disulfiram is superior to naltrexone. These are all open label trial, and many of these trials are done by D'Souza's group, Dr. D'Souza's group from Bombay. And it's also more effective than disulfiram. It's again an open label trial to demonstrate that disulfiram might be more effective when people know that they are taking disulfiram. Now, this is more hardcore science. When what do you think when you do a network meta-analysis and compare and do indirect comparisons of disulfiram and other medications? Here, those of you who are aware of network meta-analysis would know that the drugs or the substances that are in the center that are supposed to have the largest sample size or largest number of trials and are done on those. So you could see placebo, more or less. This is the story for all network meta-analysis on drugs and drugs versus placebo, that the placebo takes the center stage because most of the drugs are compared with placebo. However, you don't see disulfiram. You don't see disulfiram near the center. If you see naltrexone long-acting, or even ondansetron, and topiramate, acamprosate, disulfiram is way here, right? It's not even in the center. So that means there's a very small number of direct comparisons made. There's a small number of participants participated in disulfiram-related clinical trial when you compare it with other known pharmacological agents or approved pharmacological agents for alcohol use disorder. However, the authors, Anish Baji from Canada, they and their group, they have kind of stated that overall disulfiram seems to work best under supervised settings and could be suggested for motivated patients with alcohol use disorder committed to abstinence in general, especially if they are taking it in front of significant others. Again, it's kind of rediscovering the wheel. The way it was stated by Jonathan Chick and Colin Brewer in the 1990s, the recent meta-analysis and the network meta-analysis are suggesting that, yeah, they are, supporting their hypothesis of package and supervised administration. In terms of adverse effects, of course, you would wonder, because a lot of you are kind of, nobody has talked about adverse effect, but a few of you have spoken about drug interactions. So let us see adverse effect. You would see the very, of 40% increased risk, of which I'd say modest risk increase in terms of experiencing any adverse effect. If you consider serious adverse event, which was defined by hospitalization, which is a little higher, in the disulfiram group in terms of absolute number than the placebo group. But when they went on and checked whether there's admissions were disulfiram related, they found that those were not. Deaths 7 versus 6, again, very close to each other, disulfiram versus placebo. So with this data, we cannot say for sure that serious adverse event and deaths are more common in the disulfiram group than in the placebo group, but you must recognize the numbers are very small. So you cannot even calculate the risk ratios, or the confidence interval will be so large that that the precision of the result would be very poor. Okay, so let us now focus on some specific population. If you see somebody with alcohol use disorder and major depressive disorder, is disulfiram any better than other medications? So there is again this network meta-analysis by a Chinese group of people, Chinese group of scientists who wanted to see the effect of all pharmacological agent and antidepressant medications, and you could see disulfiram right there. So the first network diagram is for AUD remission, abstinence days. You have disulfiram and depression score improvement. So we'll see the results for A, B, and C in the next slides. So here you would see that disulfiram, when you consider it in terms of alcohol outcomes, so A, if you remember, we're going to go back to the slide, it's AUD remission. So A and B are alcohol outcome, and C is the depression outcome. So A is positive for disulfiram. The odds ratio is 5, although again, the precision is very low. The confidence level is very high. B, again, alcohol outcome, the disulfiram is positive. However, for C, you do not have a positive result for disulfiram. So disulfiram seems to improve the alcohol outcomes if somebody have alcohol and major depressive disorder. However, depression outcome might not be positive for disulfiram or doesn't produce, superior outcome to placebo. Now you think about NRIs, that is norepinephrine reuptake inhibitors. So it primarily, when I check, this primarily consists of venlafaxine, duloxetine. So it seems they tend to improve. They do not tend to improve the alcohol outcome, but they tend to improve the depression outcome. So that was the finding of the meta-analysis. Only MAOD seemed to be effective in comorbid MAOD is medications for alcohol use disorder. Disulfiram seem to be only MAOD, which is effective. You could see acamprosate, antiviral medication, baclofen, all other, you just name it, naltrexone. None of them had significant outcome when they compare to placebo when you consider this particular population of MDD and AUD. And when you do a Sukra plot, you would see the rank 1 for disulfiram for alcohol outcomes and SNRI at rank 1 for MDD outcome, as I mentioned in this placebo diagram. However, there are, of course, limitations to this evidence. The trial population, 90% men, so we do not know whether disulfiram would be equally effective in women, like in men, or equally ineffective. There are a lot of heterogeneity, as I have spoken about, that there were a lot of subgroup analysis done in the meta-analysis by Skinner, and the heterogeneity would be more than 50% in most of the cases. The overall heterogeneity when you combine the open label and the non-open label double-blind trial, the heterogeneity would be in the range of 70 to 80%. Although they have talked about supervised treatment, and you could see, if you remember the meta-analysis graph, the supervised treatment outperformed the non-supervised treatment, but the fidelity of the supervision not being tested. And the 5 of these trials are from India and from one group of researchers. There is, of course, we understand is a high risk of bias in open label trials. There's bias from the investigator side and both from patient sides. you have, that's why it's a DBRCT, double-blind, randomized placebo-controlled trial, which is the gold standard, which showed disulfiram is not effective, not more effective than placebo. However, open-label trials, supervised trials, as I showed, show very strong signals. And, we have talked about Ruth Fox and the real-world patients, where in a real-world scenario, you will actually talk about a package. You will not give disulfiram versus placebo. You will always give disulfiram as a single agent, and you will combine always with the package, the psychosocial package and the behavioral thing. So it is quite different from the trial that are conducted. However, now let us a little bit talk a little bit about the adverse effect of disulfiram. Here I have taken help from the WHO's VG base. You might be aware of this WHO database, which is maintained at Uppsala University. So there they collate all the national level data, all the national level pharmacovigilance data, and also the data from Drug Regulatory Authority. And this is fed to the prescription monitoring system of the WHO, and then this database is built. So I just checked disulfiram. So this is open access to some extent. You cannot access the patient level data, cannot access individual data, but you can access the aggregate data. So disulfiram contains, you could see there are 3,591 total reports of disulfiram so far. I think the VG base was established more than 15 years ago. So it is like the 15 years data. So quite a few, I would say quite a few report of adverse events, 3,591. And I have also given you a few snapshots of those adverse events. And I've already mentioned those that are, the top ones. So first you would see the nervous system disorders. So the large number of adverse events reported regarding headache, peripheral neuropathy, dizziness, somnolence, seizure, paresthesia, polyneuropathy. It is followed by, I could say, general disorders and administration site conditions, general disorder like fatigue, malaise, drug interactions, and also alcohol, disulfiram ethanol reaction. Many of you are worried about the last two, I guess. So your worry is not misplaced. It's actually substantiated by WHO's VG base that general disorder is one of the commonly reported side effects of disulfiram. And you have psychiatric disorders, starting in confusional state, psychotic disorders, suicidal attempts, anxiety, insomnia, hallucination. You also have other things, right? Other gastrointestinal disorders, they reported as 7%, nausea, vomiting, abdominal pain, diarrhea, constipation, and breath odor. And some hepatobiliary disorder, like I think many of you haven't talked about hepatitis, but disulfiram hepatitis is a real concern, and there are people who would vary of prescribing disulfiram because of its risk for development of hepatitis. So hepatobiliary disorder reported in 10% of those, represented 10% of those reports. When I just classified, you could see that reports that are 5 to 10%, you'll see GI, hepatobiliary, mental health, skin, and subcutaneous, and more than 10% nervous system, general disorder, administration site conditions. When it's administration site condition, it will apply only to subcutaneous implant. So I think we are not much concerned because that's not a licensed approved medication. Well, then I checked the geographical distribution of this, and expectedly a lot of reports have come from Europe. That means a couple of things. The first thing, disulfiram is widely prescribed in Scandinavian countries, as I mentioned, this Denmark, Sweden, Norway, Finland, the main Scandinavian countries have prescribed a lot of disulfiram. That might be one reason. Second, Europe has a very strong reporting mechanism, and this VG base largely dependent on the national reports. So if you have a solid, robust reporting mechanism, you'll capture more side effects and will report more. So that could be another reason. Americas, mostly I would say report from both North and South America, region, Oceania, Africa, and there are some reports from Asia as well. So here's the geographical distribution. ADR reported per year. So one would wonder whether or not the ADR has decreased over the years. You would see almost it remains stable, except for less reporting in 2012, 13, 2012 and 13. It's almost the same throughout the year. However, we must understand there are significant limitations of VG base because it's spontaneous reporting. So there is always a chance of under-reporting, and there is always a country-wise variation. More importantly, we do not have a denominator, so we do not know what percentage of people who are on disulfiram would experience these side effects. So, because we don't have a denominator, we also have a reporting bias, for instance, an external influence. What if there are a lot of media report and attention, and then this is will be more reported? There could be data quality issues, there could be duplications, reliability issues. You also do not know that whether the side effects are caused by disulfiram, because those side effects might be because of other reasons, like somebody had alcohol use disorder anyway might develop hepatitis because of his alcohol problem. So I do know this because of disulfiram. So causality cannot be associated. But however, this gives a good signal for detection, early warning, and trends. If you see something unusual happening with disulfiram, it should raise your eyebrows and warrant further investigation. And it is mostly useful for not for frequency, but more for comparison, that which of these are more common, less common, etc. So you can compare, and you can also compare naltrexone, disulfiram, acamprosate, which I did out of curiosity, but I haven't put it out in the slides because that might be a bit overwhelming. Again, Jonathan Chick and Colin Brewer, they wanted to check the national level prescription practice. It's a very old paper in 1999, but I guess the prescription practice hasn't changed much over the years. And you could see Denmark, Sweden, Switzerland, Finland, Norway, they top the list. So very interestingly, they have adjusted it for 100,000 adult population. So it is not that some countries are very large number of people with alcohol use disorder. That's why you have a lot of disulfiram prescription. So they wanted to hypothesize that why disulfiram is not prescribed, like very low prescription in the UK, in the US, which is traditionally quite not. So they thought that it might be misunderstanding of the efficacy of disulfiram or the importance of supervision. Sometimes there are no person available for supervision. The attitudes of Alcoholics Anonymous, although the Alcoholics Anonymous attitude is aligned with disulfiram's complete abstinence. However, Alcoholics Anonymous have this kind of belief of exclusivity. So when you are a member of Alcoholics Anonymous, it would tend to think that it is the attendance and participation in the Alcoholics Anonymous which has created the difference between drug alcohol use and abstinence. So there is kind of reluctance to endorse the disulfiram from Alcoholics Anonymous. These are all their hypotheses, right? What I'm narrating is not my, I think their conjecture. The fear of ADR and DER, of course, we have talked about it. And the last one they didn't talk about because that time there was so much talk about the commercial determinants of health. This is my addition to it. I would call it the generic patent paradox, and this gives me a chance to talk about why newer drugs are chosen for CMEs for this kind of presentations. That is why I was very surprised when Dr. Govind said that disulfiram would be chosen. Generally, there's a lot of pharmaceutical push for newer drugs because they want it They have just marketed it, and they want to push it to the market, push the physicians to prescribe it. So they have a profit motive behind it. But for some drug like Disulfiram, which was approved in 1950s, and which is a very cheap drug, it's way over the patent period. Why would somebody push and talk about Disulfiram? So I'm glad that we are talking about Disulfiram despite the pharmaceutical push, which is there for lumateperone and other drugs that Dr. Govind has talked about. So now you could see that's why I was very interested in understanding why Disulfiram today. Now, the brass tacks of Disulfiram. How to prescribe and monitor Disulfiram. So first of all, we just try and understand how to select patients. Your patient must be suffering from alcohol use disorder, moderate to severe alcohol use disorder, alcohol dependence. There should be full motivation and commitment for abstinence. If they are not, you might be cautious or may not prescribe Disulfiram. It might be a relative contraindication for prescribing Disulfiram. There should be significant others. As I have talked about, the importance of supervised prescription and the package. So if the significant others is there, so this is a point for prescribing Disulfiram. Somebody with a good decision-making capacity, so somebody understand the consequences of ethanol disulfiram reaction, will not just go and test it. Maybe for that matter, it's actually trust you as a physician. When you say that there will be a bad reaction, they will actually believe and trust you of experience of having a bad reaction. If tried alcohol on disulfiram, and those with reasonably good liver function that I'll discuss in the next slide, how good the liver function should be before you prescribe disulfiram. So the first thing is select. After you select, you take consent and you do counseling. So I think many of you have talked about how difficult and tedious the disulfiram consent process is, and I believe the low prescription of disulfiram is also to do with the tedious consent process. However, I must say that when you do this consent process, you are talking to your patients, you are building a relationship with the consent process itself. You can take it as a therapeutic. And as I've said, that it comes as a package. And, so therefore the consent process itself becomes very important, and it produces a therapeutic benefit for disulfiram as well. So what are to be included in the consent process? Risk of course, disulfiram ethanol reaction. One must talk about that disulfiram produces irreversible blockade of acetaldehyde, which might last for 2 weeks. So disulfiram ethanol reaction might be experienced even after 2 weeks of discontinuation of disulfiram. One should also talk about the interaction between disulfiram and other drugs and disulfiram and other products like the shaving aftershave lotion, or those or maybe the cough syrup, which might have alcohol content. And also one needs to talk about the risk of hepatotoxicity. So after you consent and counseling, the third step is prescribe and monitor. At least 12 hours of abstinence is needed. So unlike a disulfiram challenge test or the disulfiram producing an aversive response, here you would like to refrain from doing it. So you must ensure that there is 12 hours of abstinence, 12 hours of abstinence. So sometimes people do alcohol breath analysis just to make sure that, it returns a negative result before they start disulfiram, although this is not a very routine practice, I must say. 250 milligrams is the standard dose, but never beyond 500 milligrams. It's a single dose, usually in the morning after the breakfast, and preferably supervised. And the side effects that should monitor that I've talked about, so neurologic side effects, the most common one. We also have within the neurologic side effect, you have the eye side effects, optic neuritis, and one should be thinking cautious of the liver functions. How liver function should be monitored? There should be one liver function test on the baseline, then the first 2 weeks, then after 2 weeks, and then monthly for 6 months, then every 3 months. This is the monitoring schedule prescribed by, advised by the Substance Abuse Administration in the US. Substance Abuse and Health Services. What are the disulfiram? What are the contraindications for prescribing disulfiram? The first one, of course, is an absolute contraindication, which is highlighted by 2 asterisks. Known hypersensitivity, so somebody with sulfur or nickel allergy should not be prescribed disulfiram. So this is an absolute contraindication. The others are relative contraindications, psychosis, especially because they might lack decision-making capacity, especially during the time of active psychotic phase. So you don't want to expose them with, more than usual risk of disulfiram ethanol reaction, but also because of the fact there was some initial report of disulfiram-induced psychosis, although I must say those reports are based on high dosage of disulfiram, which is not prescribed nowadays. Somebody with coronary occlusion, so somebody who has experienced recent myocardial infarction and all, we would not, prescribe it, or somebody with unstable angina will prescribe disulfiram. So these are relative contraindications. In pregnant and nursing women, we have very limited data available. As I say, 90% are from men, and 10% women, none of them are pregnant. So, yeah, pregnant women, one should not prescribe disulfiram. Patient receiving or who have received metronidazole, paraldehyde, nobody prescribed paraldehyde now. So, metronidazole, alcohol, and alcohol-containing preparation, of course. Somebody who is taking cough syrup, like codeine containing or other cough syrup, which has alcohol content, it's a relative and sometimes absolute contraindication prescribing. Now, I will only talk about some clinically significant drug interactions. You are also, I think, indicated in your workload. The slide has indicated that some of you are really worried about drug interactions. The most common drug interaction, I guess, is metronidazole. Because it increases the concentration of disulfiram in the blood and thus might produce confusion and psychosis. So this is something that should be wary of. And then you have diazepam and chloride peroxide. These are important because these are 2 medications which you frequently prescribe for alcohol withdrawal treatment. So you will only prescribe disulfiram only after the withdrawal phase treatment is over, because again, it might increase the concentration of disulfiram. And disulfiram also increases its concentration in the blood. INH, rifampicin, antitubercular drugs. Some people with alcohol use disorder might also have comorbid tuberculosis. So that's why. And they may produce unsteady gait because disulfiram increases the serum level of INH and rifampicin. Warfarin, again, if somebody has an anticoagulant medication, especially people with AMI, and they might have been receiving or previous, history of infarct stroke, they might have been receiving something like warfarin. So disulfiram might increase the concentration of warfarin. You might like to reduce the dose of warfarin or may not prescribe disulfiram in those contexts. Phenytoin, a lot of patients with alcohol use disorder have comorbid epilepsy, and phenytoin might, phenytoin's concentration, serum concentration might be increased because of disulfiram, because of the site P2C9 inhibition. TCAs, seldom prescribed nowadays, but I think people still prescribe something like dothepin and all, and sometimes amitriptyline. So, again, one should exercise caution or use lower dosage of disulfiram because TCAs might increase the chances of confusion state by increasing disulfiram concentration, serum concentration. So a small note on disulfiram ethanol reaction, because this is an important entity, although I again reiterate that disulfiram ethanol reaction is not the mechanism by which disulfiram works. However, this is something one should be worried about, and one should acknowledge and inform the patient before prescribing it. So disulfiram, it's highly orally absorbed, 90% absorbed, and has a very high lipid solubility. That's why it crosses the blood-brain barrier very quickly. Disulfiram is metabolized to diethyl dithyrocarbamate, then diethyl dithyrocarbamic acid, and then is oxidized, and you also have a methylated product of DDTC in E, that is diethyl methylation. And these products, not disulfiram per se, but these products that I have talked about, DDTC, DDC, and DDTC-AME, they are responsible for blocking the acetaldehyde dehydrogenase enzyme and causing accumulation of acetaldehyde when somebody drinks alcohol while on disulfiram, and this produces disulfiram ethanol reaction. So basically, this particular step of breaking down acetaldehyde to acetate, this particular state of ethanol or alcohol metabolism is blocked by disulfiram and its metabolites primarily. So when will you see this reaction? You'll see this reaction about 10 to 30 minutes after consuming alcohol. And, the symptoms can also be triggered by exposure to all sorts of things like even alcohol-containing mouthwash, cooking wine, even hand sanitizer. Here we have a paper, we published it with the INS group, Dr. Balhara's group, where we have demonstrated that disulfiram ethanol reaction might also be produced with hand sanitizer. Almost 20% people who have used hand sanitizer during the COVID days, when a lot of people are using hand sanitizer, and have ethanol disulfiram reaction. And those who have reactions, about 1/3 of them have moderate to severe reaction. So when somebody is on disulfiram, you might exercise caution regarding using very high amount of hand sanitizers. The alcohol is consumed, as I mentioned, the disulfiram effect might last for a couple of weeks. So, even after 2 weeks, it might produce, if somebody drinks alcohol for stopping disulfiram, it might still produce disulfiram ethanol reaction. Baclofen disulfiram, blood alcohol concentration and disulfiram dose dependence is disulfiram ethanol reaction. So if somebody consumes high amount of alcohol, will produce more severe reaction. And generally with 5 to 10 milligrams, this is of 100 ml blood alcohol concentration. So this is a very low. This is like if somebody drinks like 50 ml of whiskey or maybe half bottle of beer, it might be enough to produce mild form of disulfiram ethanol reaction. And if somebody drinks up like 90 ml of whiskey, of course, it will produce a very severe disulfiram ethanol reaction. What it also entails, it's flushing. There's a lot of hypotension. There are GI effects, and there are a lot of neurological symptoms, especially headache, and sometimes it requires hospitalization. There are reports of cardiovascular collapse. There are reports of seizure, even death, and acute myocardial infarction. So disulfiram ethanol reaction can be life-threatening. It's important, and one should not, ignore and undermine the possibility of seizure and death with disulfiram ethanol reaction. Now, a small note on disulfiram hepatotoxicity. Disulfiram can produce asymptomatic transaminitis. So one should not worry about that. For asymptomatic transaminitis, usually you would see a rise in the AST-ALT level, especially AST over ALT, and then it will normalize or stabilize within a month or so. However, it can also produce very severe acute and fulminant hepatitis, even acute liver failure, even death. However, death is very uncommon. Fortunately, about 1 in 25,000 patient years is the incidence of occurrence of idiosyncratic hepatitis. As the name suggests, it's idiosyncratic, so it's not dose dependent. The pre-existing factor is pre-existing liver disease. That's why you should not prescribe it somebody with severe alcoholic liver disease, even moderate alcoholic liver disease, because that will increase the chances of disulfiram hepatotoxicity. It may develop even after months of therapy, so it's not like, so we need to monitor. That's why And although the chances are more initially, that's why we need more frequent monitoring for the initial 6 months. Even after that, we need to monitor every 3 months because it may develop after several months. And sometimes you have other idiosyncratic hypersensitivity manifestation like eosinophilia, rash, and fever. If those are there, perhaps these individuals might also develop idiosyncratic hepatitis, so one should be cautious. And there is very low evidence, as the American Society of Gastroenterology suggests, that disulfiram should not be used in the treatment of alcohol disorder along with any spectrum of alcoholic liver disease. There is very low evidence to suggest that. That means you can perhaps prescribe disulfiram with a very milder form of alcoholic liver disease. However, in moderate to severe liver disease, one should not prescribe it because of its chances of producing high hepatotoxicity. Now, as I said, that I will talk very little about disulfiram's effectiveness in cocaine use disorder. I don't know about others, but in our context in PGI, we of late are seeing, I would say, a substantial minority of patients with cocaine use disorders. So how does it work? Disulfiram, here you have a definite mechanism of action, unlike alcohol, where it's like the package and you explain it, in a very tortuous and complex way. Here it said that disulfiram blocks dopamine beta hydroxylase, thus increase the concentration of dopamine. And cocaine also increases the concentration of dopamine. So the hypothesis is because of increased dopamine, you don't get more happy, but you get dysphoric, and also it causes dopamine replacement during cocaine withdrawal phase. So it helps with that cocaine withdrawal comes with a lot of fatigue, a lot of depression. So it helps with that, and there is also a mechanism of plasma cholinesterase inhibition, and so it actually help metabolize cocaine in the periphery, so less amount of cocaine available in the brain. So there are kind of three, I would say, reasonably strong hypotheses to say that cocaine disulfiram could be a potential pharmacological treatment for cocaine use disorder. So this is the meta-analysis, which includes more than 1,000 participants. So at median dose of disulfiram used at 250 milligrams per day. Average duration of follow-up was like 3 months. And I would say that, in terms of abstinence rate, disulfiram increases the abstinence rate by 58%, but there is no certainty of evidence. Those of you who are aware of the GRADE evidence synthesis, they would know that you categorize the certainty of evidence as well. So here you would see low certainty, not a very low certainty, but low certainty. So you have high, moderate, low, and very low. Disulfiram does not have effects on the frequency of cocaine use, the amount of cocaine use, and the dropout from the study. So there are early signals to suggest that disulfiram might be a good medication, might be one of the medications for cocaine use disorder. As you would know, that there are no approved treatment for cocaine or stimulant use disorder. So this is the potential target. Here is I am at the end of my presentation. So here are the key takeaway points. Disulfiram, as I say, is the Gandalf of psychopharmacology, I think. And it's irony, as I'd say, it's interesting that the first presentation of the psychopharmacology subsection of the Indian Psychiatric Society starts with a grand old person of psychopharmacology, disulfiram. It mostly derives the evidence from open-label trials and from supervised settings. The quality of evidence could be downgraded because of the risk of bias, because of its open-label nature, and because of the heterogeneity. between the trials. However, it might be useful for people who are committed to abstinence, who have high support, and a very good decision making capacity. So, maybe handful of people, very select group of people, you might like to prescribe disulfiram. And it might also be useful if somebody has comorbid major depressive episode. We have greater evidence for that, as opposed to some, and also some evidence to suggest that somebody have comorbid cocaine use disorder might like to prescribe disulfiram. However, the practice is limited by fear, by ethical concerns, and also, I believe, commercial reasons. If you consider the cost of treatment, disulfiram, many of you would know that disulfiram one strip, 10 tablets would cost you like 35 to 40 bucks, whereas the same 10 tablets of naltrexone will cost your patient something in the range of between 500 to 900 rupees, depending on generic or branded prescription. And acamprosate, because 666 3 times a day, the cost would be as high as the naltrexone, like 990 rupees per day kind of cost. So disulfiram, it's a very cheap option, actually, economically, I could say, not cheap, economically more viable option for your patients, and that might be the reason why the pharmaceutical companies are not pushing it much, and maybe the reason why it is losing out its battle against the other medications. However, the practice requires careful selection, counseling, consent, and monitoring, as I described before. One should be especially talking about disulfiram-ethanol reaction, and this is odds of producing hepatotoxicity, especially during the consent process. And one should take note of contraindications and clinically significant drug interaction, as I mentioned in one of the slides, like metronidazole, clonazepam, diazepam, etc. Well, I'll stop here. Thank you very much. Sorry for spoiling your dinner, and I think it's 9:30. Yeah. Thank you. Over to you, Dr. Gayatri.
Thank you for this masterclass, Dr. Abhishek. And I'm sure you had us all booked for the last 1 hour. And we already have some questions for you. Meanwhile, I request everybody to please be prepared with your questions very briefly. So the first question we have is, any latest update on precautions in taking disulfiram consent?
The doctor who asked this question because I cannot understand the context of the question. Any update on the consent process, you mean to say? I don't know, because the consent process is like, you need to talk about the disulfiram ethanol reaction, the need for supervision, and disulfiram hepatotoxicity, need for monitoring. And a new thing I could say, that because nowadays post-COVID, people are used to people have gotten used to hand sanitizers. Every one of us have hand sanitizers now, using hand sanitizers in our offices, and many of your patients might have been using hand sanitizers at their homes. So this is something which you might like to add in your disulfiram consent form. However, I would love to hear you out. Doctor who have asked this question, love to hear you out if you have something else in mind when you ask this question.
I think I agree, but keeping in mind with the tradition and the new pan-Asian cuisine coming in India with a lot of alcohol used in cooking and desserts, I think that is something that we can mention. Otherwise, I think it's a pretty standard protocol that we follow.
Yeah, thanks, Gayatri, for pointing that. So, yeah, there are chocolates, of course, which are rum chocolates and all there. Those are there. Yeah, of course. Thank you for the questions, and thank you for the insight.
I welcome any other questions that we have.
Patient often comes with complaints of numbness over peripheries. So peripheral neuropathy is quite concerning. And when the patient takes it continuously for 6 months to 1 year, most of the time when they are on this medication for 6 months, they come out with severe peripheral neuropathy. We need to give up this medication. Is there any other alternative or how to cope up with this? Because even for other drugs, patient doesn't respond, especially pregabalin or gabapentin, whatever we use. We may have to give up this molecule. Thank you.
Yeah. Thank you for your question, Dr. Ganesh. Yeah, you were right. The peripheral neuropathy, in fact, neurological symptoms are the commonest, most commonly reported symptoms among all others when somebody is on disulfiram, and it might produce very significant and severe numbness, and there you might be forced to stop disulfiram. One caution just is that people with alcohol use disorder might also develop peripheral neuropathy because of alcohol dependence. So that is one confounding. The other confounding could be somebody with alcohol use disorder might also have other comorbidities like diabetes and all, which might produce peripheral neuropathy. But I'm sure that the patients that you are talking about, you must have excluded all possibilities. But it's just a kind of a general discussion, a point of caution that, it's happening while the person is on disulfiram doesn't always mean it's disulfiram induced. Of course, you can stop and see. I didn't review the literature regarding the treatment of disulfiram induced peripheral neuropathy. So I do not know whether pregabalin or gabapentin, which are standard treatment or approved treatment for peripheral neuropathy, would also work for disulfiram-induced peripheral neuropathy. I would agree with you that the safest option, if you think that it is induced by disulfiram, is to stop disulfiram and give another medication a chance.
One more question for you, sir. What is the evidence of using combination naltrexone plus disulfiram versus naltrexone alone?
So there are, I couldn't find any trial on that particularly. So if you have asked the question, if you are aware of any trial, please let me know. But whatever reviews that I have done, I didn't find any head-to-head trial of this combination. So I don't know the answer. Yeah, that's my answer.
Disulfiram induced hypertension as a side effect. Is there a link?
Yeah. So disulfiram ethanol reaction mostly produce hypotension, not hypertension per se, but the side effect list that I have reviewed, I don't remember it as mentioned as a very common side effect of disulfiram, hypertension. However, I must say that I need to, if I have to give you a very concrete and definitive answer, I need to review that whether somebody has reported it particularly. I have to look for it and disulfiram. But whatever BG-based data review that I did and the other reading, I didn't find a direct association between disulfiram and hypertension.
Any specific measures for disulfiram ethanol reaction?
Yeah, so it's mostly self-limiting. However, if the hypertension is severe, if somebody had seizure and chest pain, etc., one should be hospitalized. And yeah, so there is no definite antidote if that's the question you're asking, that you give something and it will just go away. Yeah, so it's mostly symptomatic treatment. Yeah.
If there are any other questions, now is the time. Okay. So, moving on, let's have the vote of thanks with Dr. Vaibhavi, member of the Psychopharmacology Specialty Group of Indian Psychiatric Society.
Yeah. Thank you, Dr. Gayatri. Very good evening, everyone. Myself, Dr. Vaibhavi, I would like to thank for the opportunity given. On behalf of the IPS Psychopharmacology Subcommittee, I would like to thank our patron, the current President IPS, Dr. T.S.S. Rao sir, and also our President-elect, Dr. O.P. sir. I would like to thank IPS office bearers, Dr. Arun Marwari sir and Dr. Sujit sir, along with our EC member, Dr. Hina ma'am. So this is one of the first webinars we are hosting as part of this subcommittee. I would like to thank Dr. Govind Kulkarni sir, along with the other IPS subcommittee members for taking the lead for this webinar series under the subcommittee. And also would like to thank Dr. Shaul Amin sir for all the encouragement and support. Coming to today's webinar, it was indeed a very interactive session by Dr. Abhishek Ghosh sir. Initially with the Slido and also how you took us through the journey of disulfiram. Also, point to note is the use of disulfiram in cocaine dependence was point to note. And of course, as sir appealed to give a chance, one more chance for the drug in the practice. So thank you, Dr. Abhishek Ghosh sir, for taking our time and for the extensive, informative session on disulfiram. And I would like to thank
you, Dr. Vaibhavi.
Chairman Dr. Gayatri Bhatia ma'am. Thank you for coordinating the sessions and giving your inputs as well. Lastly, I would like to thank the audience, including some of the members of IPS South Zone and North Zone, East and West Zone, along with the PGs who have joined today. Thank you, Dr. George Reddy sir, Dr. Rangnath Kulkarni sir also for joining us. Last but not the least, I would like to inform that the IPS subcommittee also hosts a quiz fortnightly. We have aired 5 subcommittee quiz on psychopharmacology alone in the last 2.5 months under the guideship of Dr. Shaul Amin sir. So I would like to request the staff and PGs to encourage more participation. You can access through ipsquiz.com and happy learning, everyone. Thank you very much for the opportunity.
Thank you and namaskar. Bye-bye.